This program is one of a series brought to you by Abbott Laboratories called Mind and Medicine, applying the behavioral sciences to the practical problems of medicine.
I have several patients with chronic lung disease in my own practice who are very functional, whose pulmonary function is no worse than other people I saw when I was a resident who didn't know me, who didn't know anything about me, who came into a big clinic and were scared stiff and were very, very symptomatic with the same pulmonary function.
That was Dr. Kent Smith from the Department of Family Medicine at the University of Washington in Seattle. And in this program, we'll be focusing on some of the psychological components of chronic obstructive lung disease.
It's largely felt as being a condition which is untreatable. There's really nothing you can do about it. And people would just as soon not see the patients.
This is Dr. Donald Dudley, a psychiatrist and author of The Psychophysiology of Respiration in Health and Disease. He is the second member of our discussion group.
It came as a great shock to me to find that when patients were referred for treatment, that the physician didn't expect the patient back. I always felt that was stealing somebody else's patient.
The third member of our group is Dr. Leonard Hudson, chief of the Respiratory Disease Division at Harborview Medical Center in Seattle. Like his colleagues, Dr. Hudson is particularly interested in the psychological aspects of treating patients with chronic lung disease.
Assisted respiration does bring up problems for the patient. This is a time when the patient is critically ill, and all of a sudden what you've really done here is take away one of his main ways to communicate. You've put a tube down his throat, and he can no longer tell you what his needs are, and you have to give the patient other ways to express himself. And this is usually something as simple as making sure he has a pad there that he can write it on, or asking the patient questions that he can respond to in simple ways with yes or no answers.
Our three discussants are all on the faculty of the University of Washington in Seattle. In bringing you this program, Abbott Laboratories hopes you'll find it useful in your practice and welcomes your comments and suggestions. Our discussion begins with a question from Dr. Kent Smith for Dr. Donald Dudley.
There's a lot of psychological component to the patient's sense of well-being. I wonder in what specific ways patients with chronic lung disease differ from other patients. If there are some peculiarities of this particular condition that would differentiate it, say, from the chronic renal patient or the chronic cardiac or the chronic rheumatoid.
One of the peculiarities is the direct connection between emotional changes and changes in physical activity and the symptom, that is dyspnea. It's very helpful with some patients to sit them down and to have them experience anger and anxiety and the dyspnea that goes along with it, and experience depression and the dyspnea that goes along with that. And also to push them and exercise them a little bit in your office and have them experience dyspnea there, and demonstrate to them that they do have some control over it, and demonstrate to them what the emotional connections are so they don't have to be so frightened of it.
It sounds like, yes, there are peculiarities to this disease, one being the direct relation of psychological symptoms, so to speak, to really physiologic symptoms. A related question would be, do patients with this particular condition tend to react in certain clear-cut psychological ways?
As they get sicker and sicker as a group, they start using more and more denial and repression because this attenuates the physiologic and emotional change, and it's quite protective. And if you treat the denial and repression, you'll find that you have a patient that very rapidly decompensates psychologically and physiologically.
Is that protective in order to that they can stand the shortness of breath, for example, which at first must be very frightening to them?
That's right. It attenuates the response to the dyspnea as well as the response to, for example, your wife getting mad at you or having some sort of disaster in the family. See, it's very important to realize that the dyspnea itself often isn't the thing that gets the patient in trouble. If you will, you could call a dyspnea the primary input. But in response to the dyspnea, the patient may get very, very anxious. And this anxiety produces more musculoskeletal activity, which places more demand on the pulmonary system, which causes more physiologic activity in the pulmonary system, and which further decompensates the system and produces more dyspnea. And this thing can just go on in a vicious circle.
Most family doctors really tend to approach speaking for myself, I guess, and others I've seen tend to approach these patients in much the same way you approach other patients with chronic diseases. You try and basically treat the disease and give them some support, but...
Well, it's an interesting issue because With patients with really severe chronic obstructive pulmonary disease, it really pays not to treat the patient psychologically very much. And in particular, it pays not to treat the denial and repression, which usually are defending the patient against all kinds of environmental inputs that might cause an emotional upset. If these patients do get angry or anxious or upset, it makes them very, very dyspneic, and it increases the metabolic demand on the pulmonary system, and it can actually produce hypoxia and hypercarbia. And I've seen patients driven into acidosis. In addition, if you push them hard enough and get them to experience some good old-fashioned depression, the drop in pulmonary ventilation occurs quite suddenly with depression. And since the patient is just already barely supporting his musculoskeletal system with the defective pulmonary system, he ends up having hypoxia and hypercarbia and possibly acidosis from the depression as well. So, in truth, if one is talking about psychiatric treatment in the traditional sense, it's something that you probably would like to avoid.
Of course, a patient with any sort of a chronic disease, whether it be chronic renal disease or chronic cardiac disease, is bound to get intermittently depressed. Is it your feeling then that you should wait until this happens clinically and then deal with it when it happens to try and treat the depression as best you can, or should you indeed try and head in at an earlier period to try and keep the patient from getting depressed?
In general, what we try to get people to do is to leave the patient alone psychologically until it's apparent that he's in some sort of psychological difficulty. That is, he's experiencing a lot of anxiety or a lot of depression or a lot of schizophrenia or whatever it is, and then apply the appropriate treatment for that particular psychiatric symptom.
This may be one of the problems for the physician. It may be apparent to you, and it would be apparent to someone if they're looking for it, but I think depression particularly is something that's often overlooked, that if we were aware of its possibility more and really looked for it, we could see it, but we often tend to ignore it ourselves.
It's my feeling from looking at the medical and surgical wards that the kind of patients they get with depression have retarded depressions, and that constitutes probably half of the total depressive population. Now, the agitated depressions are people who are depressed but who are making a lot of noise about it, and they get immediately sent to a psychiatrist because it's apparent that they're suicidal, they're threatening to harm themselves, they feel very hopeless and uncomfortable. But the retarded depressed patient is likely to feel very hopeless but not say anything about it. And he'll sit and put up with procedure after procedure and will never say anything. And the fact is that if you take these retarded, depressed patients as a group, they tolerate procedures very poorly.
So what you're saying is that we don't recognize probably at least half of the people who have depression and don't wind up treating it.
That's a guess, but I would think that would be reasonably accurate.
I would guess it's a low guess. I think there's probably even more of that. We just don't think about it on the medical ward.
Not just in chronic pulmonary disease either.
No,
I tell you,
right.
in the course of just a family practice, I think that just an extraordinary number are depressed. I think one other way that it seems to me that depressed patients present in the medical setting is with frequent somatic complaints of all varieties of various aches and pains, and it may be that they might well present, as you say, with increased dyspnea. This might put you in kind of a bind. From what you say, it leaves me a little uncertain. On the one hand, you don't really want to push these people too hard. On the other hand, it sounds like you clearly want to recognize the depression when it's there so you can make the appropriate intervention.
Usually what you see is a patient who comes in complaining to you that he's having a little more difficulty sleeping at night. He's always had it or has had it for years because of his chronic pulmonary disease. He might be having a little more trouble with, let's say, intermittent dyspnea in the morning or evening, or with emotional upsets. And this may be the only clue that you have that the patient is getting depressed. And unless you then sit down and talk to the patient about his feelings of hopelessness, you really can't pick up the cues. Usually they come in the form of a gradual increase in symptoms that just don't seem to be explained by any other modality.
So a good clinical pearl, if you will, is increased dyspnea No apparent reason, think depression.
Think depression or think anxiety, agitation, anger, or whatever.
As a family physician, we're often seeing the wife and several other members of the patient's family. Is it helpful to talk with the wife or to talk with other members of the family? Might that be helpful in picking up sort of subclinical depression before it adversely affects the patient's course?
Dealing with the family is extremely important, not just in recognizing emotions, but in organizing the patient's treatment. These patients get into a terrible bind. As their pulmonary function diminishes, they have less and less ability to express any kind of emotion without feeling dyspneic. That includes anger, anxiety, depression, feeling euphoric, feeling happy, just feeling good. Anything that places a change in the demand on the pulmonary system will produce increasing symptoms of dyspnea. And they get in what we call an emotional straitjacket. They just don't dare express any emotion at all. And as a result, when they go in to see their physician, they may find that their physician is doing things that they just can't tolerate, but they can't talk to him about it. And it tends to aggravate the situation because it makes it more probable that he's going to have some sort of an emotional outburst at some other time that will get him into physiologic and psychologic difficulty.
I'd agree with that.
Another side of this problem is the fact that as he gets sicker and sicker, he's more and more dependent on the physician and on his family. And it's a very different situation than the one that you get with an acute disease, like a myocardial infarction. With a myocardial infarction, the patient may or may not die, but the probability is that if he gets over the myocardial infarction, he'll get better, he'll go back to work, and he'll have very little residual. And he can look back at the doctor and say, "You're really a great guy, you saved my life, things are really going well." Now, the guy with chronic obstructive pulmonary disease never comes in and congratulates you for saving his life. There's never any positive feedback to the effect that, look, things are just going great, I'm getting better. The physician doesn't experience this positive feedback from the patients. It's so very important to be able to face chronic diseases of any kind. It's really an ego-defeating kind of experience to treat them.
Don, maybe you could comment on how this particular chronic illness affects the family homeostasis. Most chronic illnesses tend to be somewhat disruptive, and I presume this one is no exception, but it may have some peculiar features to it.
The family has the same problem. Instead of being worried about the patient's myocardial infarction for a period of, let's say, a few months, here the family's put in a situation where they have a guy that they know is probably going to die from the disease. He gets worse and worse year by year, and nothing seems to stop the progress of the disease. No matter what you do, his lung function continues to deteriorate. And so you have a family that may be anxious and upset or depressed over a period of 5 or 10 years, and they need a tremendous amount of support. And they need a lot of orientation about what it is they're actually experiencing.
We've found that working with the entire family so that everybody understands what the treatment program has to consist of is extremely important. Often the spouse just doesn't understand why his or her mate can't do certain things, why he or she is so short of breath. They really don't understand the disease process and don't understand why the patient is having the symptoms. And they think they may be bringing them on psychologically to meet some particular end that they have, which in part may be true, but usually there's a very marked physiological basis as well. And on the other hand, you have the husband or wife who feels that the patient should do as little effort as they can because they see the patient getting very short of breath with just a small amount of exertion and think that the patient is in fact in danger of dying, when what we would like to have the patient do is be as active as they can be within the limits of their ability. So that sometimes you have to get the family together, have them understand what the treatment process really entails, what the patient can do, and what the goals are for that patient.
One of the really important things that patients come in and ask me as a psychiatrist over and over again in the emphysema clinics is whether or not the dyspnea is going to kill him. And you have to encourage the patient to push himself in an exercise program up to the point that he gets dyspneic every day. or at least every other day if you can, and preferably 3 or 4 times a day. And experiencing the dyspnea has to be understood by the patient as not something which is going to kill him, but just as an uncomfortable symptom that he can tolerate.
There are probably just as many doctors as patients who share that misconception that if a patient becomes extremely dyspneic, then I think it makes the physician uneasy as well as the patient, and I think you're liable to do all sorts of things. You're liable to consider admitting them to the hospital. You may panic a bit yourself, which may in turn reflect itself and increase anxiety on the part of the family.
We've all heard of, and most of us have seen patients who fall into the classic prototypes of either the blue bloater on one hand, who has very abnormal blood gases and has heart failure, in fact, mainly related to his hypoxemia, but at the same time has very little shortness of breath, relatively speaking. On the other hand, you have a patient who has the same amount of obstruction, but who has relatively normal blood gases, but has a considerable amount of dyspnea. Now, that we think there are some physiological bases underlying these two differences, and in fact, probably these types of patients are relatively rare, and that most patients have a combination of these two things. On the other hand, I'm sure that there are some differences in terms of their drives to respiration that involve their central nervous system. I was wondering whether you think there's any other difference in terms of their psychological reactions.
In my experience with them, and this is just strictly a guess, but what appears to be happening is that the fellow that you call the blue bloater tends to be more depressed, tends to use more repression and denial, and tends to have a tremendous amount of attenuation of respiratory center drive. Whereas the other patient does not have that much attenuation of respiratory center drive, doesn't seem to use as much denial and repression, and certainly has a lot more symptoms, at least of the patients that I've seen.
With the combination of denial and repression really serving as protective mechanisms and the perceptual attenuation that you described, aren't you caught in sort of an emotional catch-22 here? If you have to deal with the symptoms because they're making the patient deteriorate physiologically, you're going to have to uncover some of the things that are being denied, repressed, and attenuated. How do you resolve that dilemma?
You really are caught in a catch-22, and it's a fascinating catch-22, because the resolution usually has to be by educating the physician and the family on ways of maneuvering around to avoid getting into those kinds of emotional traps. Now, the other ways of dealing with it is to deal with the patient on strictly a symptomatic level. That is, if he gets depressed, don't make him talk a lot about it. Simply treat him with the appropriate antidepressant medication. If he gets very anxious or upset, don't make him talk a lot about it. Just simply treat it with an appropriate medication to decrease the anxiety or anger or whatever it is.
Your point about the fact that these patients attenuate their intake of material, it's our feeling that these patients have to understand quite well what their disease is, and they have to play a very large role in their care. It's often true, and what interests me is that many people who have dealt with these patients in large numbers have noticed this as a phenomenon, and I think, Don, you've helped us to explain some of the reasons why, that we have to use many different ways to get this information across. It's just not enough to sit in your office in a 15-minute period at the end of your first history and physical exam and explain to the patient what he has and what you intend to do. That sometimes just doesn't come through, and you have to use longer periods of time, use other personnel, because the physician often doesn't have the time to do this himself, particularly the busy family practice physician.
That's right. You literally have to flood them with information. I know in my own practice, it's very frustrating to have a patient come back time and time again and ask me the same questions about his pulmonary disease, and to have to go through the explanation again and again and again. And what I usually do, because I get frustrated fairly easily in those situations, is that I pull in a wife or a sister or a brother or somebody like that and explain to them exactly what I mean and give them the directions, and then they repeatedly give it to the patient.
I wonder if you might be able to perhaps practically outline, Len, some of the resources that you have in your medical clinic or that the average family physician might be able to have in his office, or the kind of literature you use or where you get it? What can we use to educate these patients?
What we use is mainly aids that we've developed ourselves. It really takes some one person who's interested in the area. It usually has to involve a physician initially, and he has to give support to some other person, but the other person doesn't have to be, and in fact it's best not to be, I think, a physician. We have mainly used nurses, but it can be respiratory therapists, it can be nurses' aides. We have a social worker who is extremely effective. Some people in rehabilitation centers have found that their occupational therapists are particularly good at this because they're very lifestyle oriented, and they can get across some of the problems to the patients, and they're very interested in the patients as persons and not as diseases. One good resource in most communities is the Lung Association, in that they have a large amount of literature, and you can often take what they have and adapt it to your own uses.
This is the end of Side 1. For a continuation of the discussion, please turn the cassette over.